Okay, so my name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And the topic for today's Learn and Share conference call is cognitive function and epilepsy. And we're very happy to have with us David Nyenhuis, who is a neuropsychologist at Mercy Health Hauenstein Neurosciences. Dr. Nyenhuis, can you please briefly introduce yourself and share a bit about your clinical and research interests and also your experience with epilepsy?
Certainly. First of all, let me tell you, everybody, that I'm happy to be here. And if you do have questions, please write them down as I'm saying or as I'm talking, and then we can. I'd be happy to answer them in the other portion of the session. So, what's that?
As you said, that's a great point to mention that.
Okay. So I graduated from Calvin College here in Grand Rapids. I then went to Wayne State University, got a PhD in clinical psychology, and then went on to Boston University for a postdoc in neuropsychology. So neuropsychology is simply an area of psychology that looks at brain-behavior relationships. My first job was at Rush University in Chicago, and that was where I was really introduced to epilepsy and epilepsy patients. Rush at the time had the largest surgical epilepsy surgery program in the city. And so while I was at Rush, I saw a large number of patients pre-surgically, as well as folks who came in with memory concerns or other concerns with their thinking. I also, at the time, was engaged in some psychotherapy, primarily with epilepsy patients, and I was involved in sodium amytal testing or WADA testing as part of the pre-surgical process, which was done primarily to look at what side of the brain was dominant for language. After I was at Rush for 15 years, I moved over to the University of Illinois, Chicago for 8 years. There I was primarily engaged in research having to do with stroke, and I didn't see a lot of epilepsy patients. But in 2012, I came here to Mercy Health St. Mary's in Grand Rapids, where I'm the Director of Neuropsychology. And we have a very active epilepsy program here. And once again, I'm seeing patients pre-surgically. Once again, I'm seeing other patients who are not surgical candidates, but who have some concerns about their memory and thinking. In terms of my research, throughout my career, my primary research is in having to do with stroke and cognition or thinking skills associated and after stroke. I don't have research background in epilepsy.
Okay, great. So can you start by giving us kind of a quick tour of the brain, highlighting the different cognitive functions that are controlled by the different regions of the brain? So instead of around the world in 80 days, we can kind of do around the brain in 8 minutes. And obviously the brain is very complex, and any kind of quick overview will be highly oversimplified, but I think this would just be a helpful way to get us started here.
Okay, I'd be happy to. I'm left-handed, so I'm going to start with the left side.
There you go.
And which is really, you know, in epilepsy research, there are some what are called lateralized differences in terms of the effects of seizures on cognitive functions. And folks who have seizures that originate in the left hemisphere or the left side of the brain, their cognition or their thinking skills are more affected than if the seizure focuses in the right hemisphere. But if you look, if you put your hand up and hit your forehead on the left side there, that's the frontal lobe, and the frontal lobe is primarily concerned with higher cortical skills, so planning, organizing, things of that nature. But Also, in some areas of the frontal lobe is this language zone. And the front part of the language zone on usually the left side is associated with expressive speech, so the ability to get words out. A little further back in the area of the temporal and frontal kind of where they meet there is an area of language known as receptive language, where folks who have problems there have trouble understanding speech. And then even further back in what's called the parietal lobe, there are other language-based behaviors such as writing and reading skills. Now, if you go down to the side, basically right at your left ear and go in, you're in the area of the temporal lobe. And the temporal lobe, many of you may recognize, is very important for epilepsy and epilepsy treatment. If you go into the brain from the outside in, you're going to run into some structures on the inside of the temporal lobe, such as the hippocampus. And the hippocampus is the area of the brain where you store memories. Okay, the hippocampus is also an area where a lot of seizures arise. Okay, so we'll talk about that in a bit, right, some more. Further back in the parietal lobe, I spoke about that, and then way back is the occipital lobe, which has to do with vision. Okay. If you do the same thing on the right side, you have the same structures, but instead of language, the right side, or in most people, is associated with things like spatial skills, drawing, sense of direction, and so forth. But just like you have a frontal lobe on the left, you have one on the right. You have a right-sided temporal lobe, and you have a right-sided parietal occipital lobe. Would you like more information, Russ?
I think that's good for starters, and again, we'll get a little more in depth on some of that as we go along. So, so to what extent does the location of a person's seizure focus, or in the case of generalized epilepsies, the lack of a seizure focus, to what extent does that determine the nature of that person's cognitive impairment?
There's some questions, there's some factors that are important in answering that question, right, such as is there damage, actual damage to that area, or how long that damage is there, or also which area is damaged. So, for example, if the hippocampus is damaged on the left side, and you have what's called hippocampal sclerosis or scarring of the hippocampus, that can be an important factor in determining the amount of memory problems that you have. Right. However, if you have that same scarring, hippocampal scarring on the right side, it's less associated with problems with memory. So in some ways, some areas are more important than others in terms of just the one-to-one effect that location has on where the focus of the seizure is and how that affects cognition. Now, in terms of generalized epilepsies, and actually all epilepsies, there are, in addition to the specific location, there's more of a general effect on cognition just because you have seizures. So problems with attention, problems with focus, problems with a lowering of general intellectual functions. Those things can occur if you don't have a single seizure focus, so what we look at in neuropsychology is we look at kind of the general problems with thinking, and then we look to see whether or not there are specific problems having to do with the specific seizure focus.
Right. And in partial or focal epilepsies, when you see cognitive problems that are outside of where the seizure focus is, like you may have some problems with executive function or attention, which are primarily frontal lobe functions, but if the seizure focus is in the temporal lobe, is that just simply because when seizures generalize or when they spread, they activate networks of neurons that go into the frontal lobe? Is that kind of how it works, or?
That's the theory. There's part of it is that. Part of it is that skills like attention are pretty diffuse, so that there isn't a single area of the brain having to do with attention.
Okay. So what are the most common problems with cognitive function that you see in patients with epilepsy?
Now, I see adults, so with that caveat, but far and away the most common complaint or symptom coming in is memory. So people come in and say, I just can't remember the way I used to remember. But there are also problems with attention and executive functions. Now, if you look at memory, some of the problems actually, even if somebody complains of memory, sometimes it turns out to be an attention problem. Because if you think about it, in order to remember something, you have to get it in your head, so to speak, in the first place. And if you have problems with attention and you can't focus on things as well, then you're going to miss information. And then later on, when you try to remember it, it's not there. But not because you forgot it. It's not there because it was never well seated in the first place.
Right.
But memory, by far, memory is the biggest problem.
And can you talk about the different types of memory and which specific types of memory are more likely to occur with epilepsy?
Certainly. I neglected to start this, though, by saying that there are many patients with epilepsy who don't have cognitive problems.
Right.
Okay, so, and I think that's important. I see patients because they have cognitive problems, but there's a whole lot of people I don't see, of course.
Exactly.
And that's because they're cognitively normal, or they don't have any complaints at all. But in terms of memory, memory's been divided up into a number of different subgroups. So all of us have autobiographical memory, or what is commonly called long-term memory. So things that we learned when we were children, things like words or the definition of words, things like where we lived, where we went to first grade, what our older brother's first name is. That would all be kind of autobiographical. There's another part, and that really isn't as affected by epilepsy as other types of memory. The type of memory that's affected the most is called episodic memory, and that's memory of basically learning new things. So when I'm testing for it, I'm teaching people lists of words or stories or shapes, things that they didn't know before. And I'm checking how quickly they can learn those things, and I'm checking how well they hang on to those things. Now, there's a whole other area called procedural memory, and this is kind of motor memory. And so, for example, if you're driving, procedural memory is how much you press the accelerator, how much you press the brake. It's separate from language. It's separate. It's not really episodic, and it's not as affected as episodic memory is to things like epilepsy.
And is that also sometimes referred to as short-term memory?
Yes, kind of. Now the psychology. I won't bore you with the actual definition of what short-term memory is,
But in the general population, short-term memory means learning new things, okay, from day to day, whereas long-term memory is memory from long ago. And I think that's a good rubric. I think that's a good way to take a look at it.
Right. And where does working memory fit into that?
Oh, good question. Working memory is more of it's one of the executive functions. Okay. So it isn't really memory at all as much as it's planning, organization, dual tasking, doing things, taking information, changing it in your head, things like that. And I wish it hadn't been called memory because it's more of a high level thinking and arranging skill.
Right. It's probably called that because it involves holding several pieces of information in your head at the same time and being able to process those. But yeah, it's confusing because people think of that as a memory function, and it's really executive.
Right, and people with epilepsy who have trouble with working memory usually also have trouble with attention skills and focus. Okay.
And do you ever see specific learning disabilities that are related to the seizure focus? Like, if someone has the seizure focus is in the area that controls reading, would you be more likely to see dyslexia or things like that?
Well, you would see more language-based disorders depending on when the seizures started. So, for example, if they started at birth, then there's enough what's called plasticity in the brain so that maybe other areas of the brain might take over. But if somebody starts having seizures at age 5 or 6 or 7, and it's in the left temporal area, yes, they're going to have problems with some of the verbal areas of learning. So reading, writing, and so forth.
Okay. So what are some of the key, we kind of mentioned some of them already, but what are some of the key epilepsy-related factors that influence cognitive function, and can you speak to their relative influence?
Okay. The ones we know most about are things like age of onset and seizure frequency. So basically, the earlier a person begins to have seizures, the earlier in their life they have seizures, the more problems they have with their thinking skills. The more common or the more frequent that they have, the seizure frequency also is associated with learning or cognitive problems. There are other areas, other things that we know about that affect cognition or thinking in epilepsy. One of the big areas has to do with, again, I've already mentioned this, but where if the seizure focus is in the left or dominant hemisphere for language. So if you have scarring of the hippocampus in the dominant hemisphere, that's going to be associated, other things being equal, with lower cognitive or lower thinking skills. If you have epileptiform discharges between seizures, that's associated with cognitive skills. If you have multiple medications, so instead of taking one medication, you're on 2 or 3, that will be associated with problems with memory and attention, especially. And then the last thing I want to touch on right away is epilepsy is, as I'm sure a lot of the listeners understand, and sometimes we're not sure why it starts, but other times it starts after a stroke or after a brain injury or after a meningitis or an illness. And the problems with thinking may be associated with not only the seizures, but whatever caused the seizures. So if you have a serious head injury, you may have cognitive issues just from the head injury, which may be made worse by ongoing seizures. In terms of kind of ranking those, the relative influence, I'm not sure I want to do that because I think it's not always the same in everybody.
Right.
The things we know most about are the age of onset and the seizure frequency.
Sure. And when you mentioned that earlier onset tends to be associated with more problems, that is somewhat contradicted by the whole idea of plasticity, and that plasticity is likely to be higher when you're younger. So can you talk a little bit more about that contradiction, I guess?
Yeah, I don't know if it's a contradiction. I think that when it comes, I think it comes back to our discussion about problems with thinking associated with focal areas of damage versus generalized problems just from having seizures. Okay, so plasticity really comes into play when you're talking about specific areas, exquisite areas for thinking skills. So, as I said, like language areas, very early on, you could have plasticity. The brain is flexible enough, especially early on, so that if a language area is messed up, the brain can go to another area and kind of use that more as the language area. Right. But at the same time, having seizures for that long is still going to have kind of a negative effect on overall thinking.
Right, right. Okay, great. So in people with epilepsy who also have other conditions that can affect cognitive function, things that we've kind of mentioned like stroke or Alzheimer's disease or traumatic brain injury or intellectual disability, autism, is there sometimes a failure by patients or family members or others to recognize the role that epilepsy can play in cognitive function, maybe assuming instead that all of the cognitive difficulties are due to the other condition? And if that is the case, why would it be important to, attend to epilepsy as well as a possible cause of some of these things?
Well, I think it is. I think, for example, when let's just take Alzheimer's disease as an example. I mean, the memory issues with Alzheimer's are at a 3 or 4 magnitude greater than the usual ones associated with epilepsy. Right. And so the thought would be, well, I guess if there's memory problems, it must be Alzheimer's. But actually, not only with epilepsy, but any time you have multiple brain-related problems, the cognitive or the thinking implications of those problems are at least additive and maybe multiplicative. Sorry for the large word. Right. But basically, if somebody's memory is due to a combination of like Alzheimer's and epilepsy, if you can treat the epilepsy, then although the Alzheimer's is still there, you're likely to see at least some short-term improvement in their overall thinking abilities. So it is important to recognize the effect of epilepsy on memory and other cognitive skills, because in most patients, in a lot of patients with epilepsy, it can be treated. And by treating the seizures, you can see some improvement in terms of the thinking.
Right. Okay. So all anti-seizure medications have at least the potential for cognitive side effects, but which ones have, the best or the least favorable cognitive profiles?
Well, certainly the older ones. Mm-hmm. The phenobarbital, phenytoin, carbamazepine, valproate, the first generation epilepsy agents they were great for controlling seizures in a lot of cases, but they had very significant cognitive side effects. And that's why there was such a push, that's one of the reasons why there was such a push for kind of this next generation of epilepsy meds. Now, of the newer epilepsy meds, there haven't been a lot of side-by-side comparisons of how they interact with thinking. Right. The one that has gotten the most kind of, I guess, negative press in terms of cognition or thinking is Topamax or topiramate. And that's just, in some patients who take Topamax, they notice a significant decline in their skills. And it's a difficult thing because sometimes the patient has to, sometimes the Topamax is given because other agents aren't as effective in controlling the seizures. And so changing it may improve cognition for the short term, but on the other hand, if it's the one that works, it may also increase risk for breakthrough seizures.
Right. So in most cases, this is a difficult question, but would you say in most cases the positive impact of improved seizure control that you get from anti-seizure medications and then therefore the improved, the positive impact on cognitive function from having better seizure control, does that outweigh the negative impact of side effects on cognitive function?
That's a great question, and I'm hopeful that maybe once we open up the mic to everybody that maybe we can discuss this more with people's individual lives, because while I would start with a general statement agreeing with it, that in most cases the number one reason people take the medications is for seizure control. Okay, and if your seizures are under good control, so for example in Michigan, if your seizures are under good control for I believe it's 6 months, then you're able to drive. Then you increase your independence. Then other good things happen. And even one breakthrough seizure can kind of get you to the back of the line again. So there are big implications to not having good seizure control. On the other hand, sometimes I see patients referred to me because they're having such difficult times with their thinking, and they haven't had a talk with their neurologist or epileptologist about alternatives. And I would certainly have that talk. They may say to you, yeah, we were afraid to change because of this reason or that reason. But if you haven't had a lot of experience with some of the other agents, they may be open to giving that a shot. So it really is, it's really up to the individual and their doctor.
Sure. And as you mentioned earlier, probably higher likelihood of significant side effects and cognitive side effects if you're on polytherapy or multiple medications. So that may be one other thing to discuss is, can we maybe, if we're on 4 medications, can we maybe get down to 3 or something like that?
Certainly.
So what does the literature say about the impact of other epilepsy treatments like vagus nerve stimulation, surgery, or the ketogenic diet on cognitive functions?
Okay. We know the most about surgery.
Okay.
And what we know about the most common surgery is a partial temporal lobectomy. Right. So taking out that area of the temporal lobe, that's a focus for seizures. And what we know is, especially if it's a left-sided lobectomy, that a substantial minority of patients will lose some memory skills if you compare their performance before versus after surgery. Now, there's a number of factors, even within surgical patients. One is, if they had significant memory problems before the surgery,
then they're at lower risk for additional problems with memory after surgery.
Okay.
Another important caveat is that the same relationship isn't nearly as strong for right-sided temporal lobectomies. So we don't see the degree of memory, post-surgical memory impairment on right-sided, assuming that that's the non-language side, on right-sided surgeries. The other issue that we see post-surgical is naming issues or problems coming up with words. And that, again, it follows the same pattern as memory, in that it's more prominent in folks who didn't have naming problems before surgery and more prominent in folks who have a left-sided lobectomy. So that's surgery. Do you have any follow-up questions about that, or should I move on?
Presumably we know less about extratemporal surgery, but do you know anything about like frontal lobe surgery, for example?
Yes, we do know much less about it. And the cognitive implications of like frontal lobe surgeries are not as apparent. I'm pretty confident in saying that. Yeah. Not as apparent as the temporal lobe. With the frontal lobe, you might see some decrease in attention. You might still see some naming issues, especially if it's if it's on the left side that the resection takes place.
Okay. And then, so vagus nerve stimulation. I've heard some some information about it being possibly a particular benefit to people who have intellectual disabilities, but haven't seen a lot of that. But
no, there isn't a lot out there. What I have heard is that first of all, vagal nerve stimulation doesn't hurt thinking skills,
right. And
there is some literature to say that it could improve some thinking skills. A lot of people think that that's because of an indirect effect, because it has, in some patients, a nice effect on mood. So depression is lowered, and because the mood is better, that is associated with better focus, better attention. But other than that, I haven't heard a lot of direct effects on with regard to vagal nerve stimulation. Perhaps some of our listeners have heard that. Yeah. In terms of the third one that you asked about is the ketogenic diet. And the ketogenic diet is, again, there isn't as much known about it. It's a little more controversial because even though there's some literature to suggest that there's improved cognition, especially in kids who have the ketogenic diet, there's also some animal literature to suggest that it has a negative effect on cognitive functions. But the ketogenic diet, the thought is that if seizures are, if the frequency of seizures goes down significantly, then that in itself would improve overall cognitive function rather than any specific mechanism associated with the ketogenic diet.
Right.
But we don't know as much about that either.
Sure, and that's the difficulty with any treatment, is knowing whether it's a direct effect on cognition or just simply an indirect effect of having fewer seizures. So, Can you talk briefly about the benefits of getting a neuropsychological evaluation and what's typically involved?
Yeah, the benefits, I think, probably are related to how specific the referral question is. So neuropsychological assessments are
I think most beneficial from a diagnostic standpoint. So somebody comes in, they have a problem, and through the testing, we can see if, in fact, by their test scores, it is a problem, how significant of a problem it is, and we have some good clues as to what may be causing the problem. So, for example, if somebody is coming in with epilepsy, they're on 2 or 3 medications, and they're also very depressed and anxious, we may be able to assist in teasing out, in some cases, what we think is the prominent reason for the problems with their memory and attention. Okay. Secondly, the benefits for a neuropsych evaluation in pre-surgical candidates are in addition to these general diagnostic questions. So the neuropsych evaluation for pre-surgical patients can assist in kind of cementing the focus or the area of the brain that is affected by the seizures. So, for example, if somebody, again, has left-sided seizures, left temporal seizures, and they've had them a long time, and there's hippocampal sclerosis on the left side, and they show that their language skills aren't as well developed as their spatial skills, all of those things kind of go together towards making them, other things being equal, a good surgery candidate. The other thing that a neuropsych evaluation can do with the pre-surgical candidate is we'll be testing memory pretty heavily, and it gets back to this risk of a loss of additional memory associated with surgery. So we can say if somebody has significant problems with their memory before surgery, we can tell the doctor and tell the patient that they would be at lower risk for additional memory problems because of the surgery.
Okay. And how much does a neuropsychological evaluation differ from the type of evaluation that might be done in a school setting, either by a school psychologist or a social worker, maybe, to determine eligibilities for special education services or that type of thing?
Yeah, that's a great question, and it really depends on the district, okay? So, but usually a school psychologist is really going to focus on the academics. So they're going to get an understanding of Johnny's ability to read, to understand what he reads, to do math problems, those types of things. They may not get at underlying issues such as Johnny's memory skills or Johnny's attention skills in the depth that a neuropsychological evaluation would get into. But sometimes, in some districts, school psychologists are pretty well versed in a general neuropsych eval.
Okay. And under what circumstances can a neuropsychological evaluation be covered by health insurance? I know it depends on the insurance, but in general.
Yeah, it really does depend. And some you can have you can have the same condition, and one insurance company will allow an evaluation or pay for it, and another will not. But most of the time, a neuropsych evaluation is allowed by most insurance companies and paid for by most insurance companies if there is a medical reason for the evaluation. And a good medical reason, one that usually passes muster, is if a physician refers and talks about memory issues that have to be explained or other cognitive issues that have to be explained. I find that these days getting approval for a neuropsych evaluation is actually easier than it was 10 years ago.
Okay, that's good. And I know you don't do pediatric, but are you aware of how often a school system will pay for that through an IEP or through special education?
My wife is an elementary school teacher, and what she tells me, and I'm sure our listeners have heard this elsewhere, is it depends on how loudly you yell.
Right.
How persistent you are, and what case you can make. So if you feel like after an evaluation by a school district is insufficient to getting at the root causes of somebody's learning problems,
right,
then you can justify that with by either through a note by your doctor or then in a lot of cases they will pay for it. Okay. But again that really depends on the school district and frankly what their financial situation is.
Sure. So you mentioned the biggest value of a neuropsychological evaluation is on the diagnostic side, but a report from a neuropsychological evaluation typically includes some recommendations on how to deal with the cognitive challenges that were identified. And because these behavioral changes can be hard to adopt or maintain, how can patients find assistance in actually putting these recommendations into place, and what types of professionals can help with that?
Okay, well, the first set of people aren't professionals at all.
Okay.
The first would be the family.
Yeah.
And it depends on family dynamics, and it depends on how well family members interact. But what I do with every neuropsych eval is I have a feedback appointment with my patient. And I encourage them to bring family members in. And when I talk about things that can be done for memory issues, I speak to the family members, and in a lot of cases it can be, using a team approach. There can be some significant changes in behavior. So that's where I would start. Other than that, there are a number of different professionals out there, and rather than focusing on the titles like neuropsychologist versus social worker versus OT versus coach, life coach, I would ask potential candidates what their experience is with type of behavior change that is wanted. So I know of good life coaches who are very good at setting up ways to change behavior and checking in with patients. They do a fine job on that. But they're not as well versed when it comes to depression and anxiety and barriers to change. So if there are a lot of psychological issues, then I would probably go with somebody who's trained, such as a psychologist or a social worker, who can not only work on the behavior change, but also can work on some of the psychological issues that are at play.
Okay. So with cognitive problems, there are two main approaches to addressing them. One being interventions that actually improve cognitive functions or prevent further decline, and then compensatory strategies or ways to work around existing cognitive challenges. So let's start by talking about some of the possible ways to improve memory or attention and other cognitive functions. So I'll just list some different strategies, and you can maybe talk briefly about the possible benefits and limitations of each. So obviously we've talked a little bit about this already, but changes in anti-seizure medications.
Yes, and you mentioned it. Trying to get people down from 3 to 2 to 1 medications is important when it comes to improved cognitive functions. But again, it's a talk you need to have with your neurologist about risks and benefits and what risks there might be in terms of seizure control. if things are reduced in terms of numbers.
Okay. What about improved sleep? Obviously, sleep disorders are more common in epilepsy, and anti-seizure medications and seizures themselves can interfere with sleep. So I would imagine that in some cases, sleep could be a contributing factor to cognitive function. Have you ever seen improvements by improving sleep?
Yes, I have. Now, it's very interesting, though. I know that sleep problems are more common in the literature in patients with epilepsy, but in comparison to other patient groups I see, I find that epilepsy patients sleep better. And I think that's probably the kind of the sedative effects, perhaps, of some of the medications that they're on.
Okay.
So that's just a sample size of one, of mine. But it's interesting to me that that's very different than what the general literature says.
Right.
The thing with sleep is that, especially if you have somebody who is getting older, like me, in their 50s, if they are also a bit obese or getting up there in terms of weight, one of the things I would look at with sleep is obstructive sleep apnea, and asking their partner if they sleep with a partner about whether or not they snore or whether or not they appear to have very brief periods of time when they're not breathing, because that will improvements through using a CPAP device will improve sleep in the majority of folks. And sleep in general, if you can improve it, it affects a lot of things. It affects mood for the better, it affects energy, it affects attention, it affects memory. So, yeah, it can be an important contributor.
Okay. I've also seen some studies on the benefits of exercise, even some studies showing that, exercise can even lead to the generation of new nerve cells or new neurons. So can you talk a little bit about anything you know about exercise and the benefits on cognitive function?
Oh, yes. I love to talk about exercise. It's the first thing I talk about with my patients.
Oh, okay.
Because the research on aerobic exercise, that's exercise that causes you to sweat, or exercises that increases your pulse rate. There is more and more good research, solid research, showing not only improved cognitive functions like attention and memory in folks who exercise, but also, as you said, some underlying mechanisms for that. So I thought there's also not only the one that you were mentioning, Russ, but there was a recent study looking at pre- and post-MRI scans in folks with memory complaints. Who one group was randomly assigned to exercise, the other wasn't, and they found less brain shrinkage in the exercise group. Wow. So I think exercise has been shown to improve mood again. It improves thinking skills. It's at the top of the list when it comes to change. It also improves sleep. So I'm a big exercise fan.
Great.
If you would like, I can go on about what I would suggest with exercise.
Sure. Maybe briefly touch on that.
Yeah. What I recommend is, at least in Michigan here, is that you have one piece of exercise equipment in the home, and probably the most cost-effective one would be a recumbent stationary bike. You can get those at a Walmart for $250, $300. And the recumbent ones are the ones that you sit lower. They're usually bigger seats, and the pedals are in front of you rather than below you. And I find that for my patients with epilepsy, if you have a seizure, for example, while you're on the exercise bike, you're not going to fall as far as if you're on a regular standard bike.
Or a treadmill.
With other patients I see with balance issues, it's also a better thing.
Right.
So
I like exercise bikes because 3 or 4 months out of the year, it's not all that easy to get out to a gym. And if folks with seizures sometimes have some difficulties in terms of getting rides to gyms. It's something you can do in the home and something that will improve your life. I really feel that.
Great, great. What about stress management and treatment of coexisting mental health problems like depression or anxiety disorders? How can that impact cognitive function?
Well, generally, improvement in mood, and I wrap depression and anxiety under this rubric of mood, are associated with improved cognitive functions. So whatever you can do, and that includes medication, in some cases it includes psychotherapy, time-limited psychotherapy. In many cases, both medications and psychotherapy. Whatever you can do to improve your mood, you will likely have an added benefit of optimizing your thinking skills.
Okay. And what about actually adding a medication, like in the case of ADHD or if you have dementia, coexisting dementia? Can you talk a little bit about the use of medications to actually improve cognitive function?
Well, if there are diagnoses to back the need for the medication.
Right.
So ADHD medications, those are stimulants for by and large. And if somebody meets criteria for attention deficit hyperactivity disorder, then yes, I would, under the care of your epileptologist or neurologist, you can get improved attention skills. Now, it's not a magic bullet, and sometimes the medications themselves just offer people an opportunity to make the behavioral changes that are necessary for more long-term results. Similarly with dementia. Now, with dementia, the primary medications that have been that are out there are for Alzheimer's disease rather than dementia in general. And those medications are more effective actually in slowing down the process than in improving the cognitive functions.
Okay. And what about brain training, which is, you hear a lot about it now with software or games or things like Lumosity that at least claim to improve overall cognitive function. I've heard very conflicting things about that. So.
Yeah, and again, this is one person talking.
Sure.
But I'm not a big fan.
Right.
Okay.
And that's mostly what I've heard too from most neuropsychologists is that.
Well, the research just isn't there.
Right.
And when I would, if somebody's going to make one big change, I'd rather that they increase their exercise.
Right. Right.
But the issue I have theoretically with some of the brain games is that we are actually active cognitively all day. Mm-hmm. We talk to people, we listen, we write down things. All of those are cognitive tasks that require the brain to be working. I'm not sure that doing brain games actually makes the brain work any harder. I think it just works differently. So I'm not sure about the theory underlying it. And then I'm also not all that impressed with the level of data that's out there now that supports brain games. I mean, if you're going to do them, I'm kind of cheap. So if you're going to do them, I would probably stick to the ones that, like Sudoku, things that you're not spending a lot of money on, rather than a Lumosity.
Right, right. And so as kind of an alternative more towards what you were just talking about, what about the benefits of just being in a generally cognitively stimulating environment and social activity and hobbies and things like that?
Certainly. And there is some research showing that the more socially active you are, the better long-term cognitive outcome is associated with that. So yes, but that only, it isn't only because of cognitive skills. It has a lot to do with your mood.
Right.
And again, better mood equals better cognition.
Yeah. Are there any other things? I mean, I know some people talk about nutrition, but as far as I know, there's very limited evidence of any specific foods or nutrients that are beneficial for cognition. But anything else you wanted to share, for example?
Not really. I really think that there's the best evidence, again, is for the exercise.
Yeah.
And then the other ones that we've talked about, as we've said.
Okay. So now let's talk about some of the more effective tools and behavioral approaches that can be used to help people get around cognitive barriers instead of trying to improve cognitive function, just helping people to cope with them or adapt.
Mm-hmm. Yes. And in general, I think we'll probably talk about some specific ones, but the general rule for me has to do with taking an active role in getting information in. Mm-hmm. So whether that be by writing things in a notebook or writing things on a calendar on your smartphone or iPad, just the act of writing it down forces your mind to be active. And you could write it down and then throw it away, and you would still remember it better than if you hadn't written it down.
Right.
So in general, I'm a fan of anything that's going to take passive listening and turn it into some sort of active process.
Right. Okay. So they can, if we want to talk about these types of techniques, we can kind of arbitrarily split it into HighTech Solutions and then LowTech Solutions. So you mentioned smartphone apps, or there's other assistive technologies for cognition. Can you talk about any tools in that arena that you've found to be particularly helpful?
Setting alarms on your smartphone really helps in terms of can really help in terms of making appointments, or you can have different alarms for different things. They're best used when there's something specific, like if you have to take your medication at a certain time, you can have a medication alarm. Or if you have an appointment, let's say you have to go see your doctor and you have to leave at 10 a.m., and you can have a different type of alarm go off. And that's I think probably some type of system either on your phone or on your iPad that's going to give you more give you warning. The other thing I like on especially some of the larger ones like the iPads are the boards that you can write information on, because again, that's turning something passive into something active.
And what about some more low-tech solutions, sticky notes, both external memory aids versus internal memory aids, things like that?
Yeah, sticky notes, again, I'm not a big fan, just because I think your whole house can turn into a big sticky note.
Right.
I would much more recommend a single, inexpensive, small notebook, and one that you can take with you, kind of like your phone. And at the beginning of each day, it can either be a day minder or it can just be a 99-cent, dollar store notebook, spiral. And at the beginning of the day, you just put the date on it, and as you get information during the day, whether that's coming from phones or other things that happen, you write it down on that page. And the reason I recommend that is that you only have to, the behavior change, you're only doing two things. You're learning to write things down more often, and you're learning to take that notebook with you. And if you get those two things down, you'll always have that source of information with you.
Right.
So that's the best low-tech solution that I would.
Sure. And something, you know, even our family has used as it's a little better than sticky notes is the we have a dry erase marker and write things on our bathroom mirror, and that way, you know, long-term things can stay up there for a while, but short-term things, once we get them done, we just erase them, and it's not that obtrusive, and it's we found that to be helpful just as a.
Oh, that works. Or else a central calendar.
What was that?
Yeah. Or else a central calendar.
Right. Exactly.
And you can get, you know, a calendar that's maybe 2 by 3 or something like that, so that you can write things in for each day.
Sure. And what about internal memory aids like mnemonic devices and that kind of thing? Do you find those to be as helpful or not?
I don't personally find them to be as helpful with patients I see. I think that, and again, it's very individualized. It's a process that takes a lot of practice, and you're learning a new skill, and you have to kind of keep it up. And there are some people who will do that, but in most cases, that's not the case. I don't have as many success stories as I have with just a notebook.
Right. So, like for an example of like remembering a name, it may be just easier to write that name in your journal than it would be to come up with a mnemonic device for remembering that name. But for some people, the mnemonic device might be helpful. So.
Yes.
Okay. What about some school-based solutions? Again, I know less experience with this as working with adults, but any particular school-based solutions that you're aware of that tend to be helpful?
Yes, actually, I do deal with some college-level students, and certainly accommodations can be helpful. So. And it depends on the particular problem. If it's an attention problem, then an accommodation that they could petition for would be being able to take tests in a quiet environment. Or if it's a reading disorder that's associated with epilepsy and that's documented, they may successfully petition for accommodation in which they get books on tape or lessons on tape rather than having to read the textbook. Sure. Finally, in some cases, if it's very severe, there are some colleges that will have a scribe. Somebody will take notes for you. Or else another accommodation could be allowing you to take a tape recorder to class and then transcribe the notes later. So the key to all of that is to have an evaluation that looks at specific areas of reading or specific reasons for academic problems, and then coming up with accommodations that fit those problems.
Right. Any other suggestions in terms of things that can help people to get around cognitive barriers?
Well, one that we haven't talked specifically about has to do with accommodations at work, right. and very similar things to accommodations at school. Sometimes there can be fairly simple things like having a supervisor write down 4 or 5 tasks that a worker has to do at the beginning of the shift, rather than say them out loud because they may forget. Things like that. Right. That can actually have an impact on the ability to be at work and to work successfully.
Right. Okay. So cognitive challenges can often put a strain on family relationships. So what are some common complaints that you hear from caregivers and patients in this regard, and then, or not complaints, I guess, but challenges, and then what are some general tips to help minimize this strain?
Okay, well, now the first one I'm going to mention isn't specific to cognition, but is very specific to families where somebody has epilepsy, and that is issues of independence.
Right.
So the adolescent who's not able to drive or may not be able to get a job because of seizures, may not be able to move out when they see all their other friends move out. Although there's not as much stigma on that these days than there was a generation ago. That's a big issue. So working with families to change a relationship from a parent-child to an adult-adult relationship, but one in which one of the parties, the adult, one of the adults needs help from the other one. That's probably the biggest thing that I see in terms of challenges within families. Yeah. Other issues have to do with underemployment and costs and financial burden associated with the disease. That can certainly put a strain on the relationship. In terms of tips, I think working with a therapist on setting realistic expectations, I think that's a big one. All of us as parents, we believe our children are going to grow up, we're going to, raise them, and then they're going to go. And that might not be the case. If somebody has epilepsy, they may not be able to live by themselves, or they may not be able to support themselves. So looking at the new normal or the reality or the expectation, I think is important. Educating family members about cognition, about the types of issues that a patient is having. So what's hard with some of the attention issues in patients with epilepsy is that sometimes they can attend, but it's not consistent, and that's hard for family members, because right away family members will see it as an effort thing, or not trying, or something like that, rather than it being just kind of a weak cognitive area. On the other hand, a tip for the patient is to show other families or demonstrate a willingness to work on the areas that you can work on, because I think that sometimes patients with epilepsy can kind of collapse into failure, where they're not doing things that they can do, and that increases stress in the family unit. And then finally, a tip would be to choose your battles. And I see this with families with patients with a variety of cognitive issues. Correcting somebody every time they're wrong on a fact or on a memory isn't productive, and it just kind of makes them feel bad. Right. Instead, choosing those areas, if you have to correct, maybe for safety reasons, or maybe when they ask for help, then the correction is going to be met a lot more positively by the patient.
Right. I'm glad you mentioned the issue of cognitive problems kind of waxing and waning, and people misattributing difficulties to lack of motivation, because we see that in the school system too, because maybe a child had a good semester and they were doing well because they were their seizure control was good, and then they start having more seizures, and then suddenly their cognitive function and their school performance starts to slide a little bit, and that a lot of teachers who may not be familiar with that might then say, well, they're just not trying hard enough because I know they can do this because they did last semester.
Right.
Okay, so before we open it up to questions, did you have any final thoughts on this topic that you'd like to share?
I don't. I think we covered all of the main areas.
Okay, great. So let me unmute all the lines, and also after I unmute the lines, I'd still encourage you to, if you're not asking a question or making a comment, to mute your line, either using the mute feature on your phone or by dialing *6. And then if you want to unmute your line to ask a question, you just dial *6 again. Okay, so let me unmute everyone.
All guests have been unmuted. You will now rejoin the meeting.
Okay. Before we have questions, does anyone want on the call who's dealt with problems with memory, attention, or other cognitive functions want to share what tools or strategies have been most helpful for you in dealing with these challenges?
I have trouble remembering. This is Jenny. I have trouble remembering taking my medication. I take it 4 times a day.
Okay.
And my friend will remind me. And I also have this pill alarm. And if I didn't have that and my friend reminding me, I'd say at least half the time I wouldn't even be taking the medicine, or I'd be taking it an hour or 2 later when I'd suddenly remember it.
Sure.
And one thing is, I'm no good at remembering names. And for me, it helps if I think of, I can't think what it's called. You mentioned it. See, I don't remember like that. I have trouble with it. But if I can think of something that helps me, like I remember this person I met, Henry. I don't know if any of you remember the song, but Henry VIII, I am. Not singing because I got a lousy voice, but I remembered him. I think, oh, he's Henry VIII. I remembered his name.
Sure.
At least I didn't just say, hi, Henry VIII. They'd have looked at me like I was nuts or something. But that helps me, but, everybody's different. What helps one doesn't help the other.
Sure.
Those 2 things help.
Okay. And so someone has TV on in the background or something. Is it possible to either mute your line or turn the TV off? Okay, great. Any other people want to share strategies that they've found helpful or tools?
Okay, this
well,
is
she could just make a schedule and list the dates and put 4 squares for each time and X them off as she takes her meds.
Mm-hmm.
Yeah, that's a good idea.
Okay.
Excellent.
Someone else is going to say something?
Yeah, this is Sandy.
Yeah.
When I first started taking meds, I was like 8 years old, 8, 9, and my mom used to put out little shot glasses and put my meds in there.
Little what? I didn't catch
little
that.
Little shot glasses.
Oh, shot glasses. I thought you said sunglasses.
Oh, no, little shot glasses. And that way it was always visible because, you always forget. And then after a while, it was up to me to fill them. I mean, she was always helping me, but then I got used to filling them on my own because then it made me more conscious that I had to take the medication.
Right.
And I was less apt to forget to do it.
Right. So similar to the idea of writing something down, and even if you throw it away, you're more likely to remember it. If you're the one putting the pills in the container or the shot glass or whatever you're using, you're going to be more likely to remember that you have to take it later.
Right. And plus, the shot glasses was good, especially as a kid, because I could see it.
Sure. Yeah.
And then now, I still take my pills 4 times a day, but I do the week container.
Okay.
And like, like today I'm going to be gone for a while, so I'm going to put my evening pills in my pocket in case I'm not back in time, so that I have them with me. And then I always have my reminders in my phone.
Great. Yeah, and I've noticed a couple people mentioning backup systems. So you have one system to remind you, and then you have, a family member who helps you, or you have an iPhone alarm as well. So having multiple systems helps too.
I just put a little hourglass picture in the phone.
Right.
So it pops up at a certain time every day.
Okay. Great.
Wow, that's neat.
Anyone else want to share anything, or do you want to move on to questions?
This is Marissa,
Yep.
and I just thank the doctor in regards to writing the notes down. I do have a bunch of sticky notes, and I am going to go get some small notebooks. I never thought about it like that, and I don't know why I never thought about it. I have a daughter who's a journalist, and she keeps her little notepads, notebooks in her purse and all, but I never thought about it, so I'm going to do that too.
Great.
Well, that's great to hear.
Excellent. Okay, and does anyone have any questions now that you'd like to ask?
No.
I have a few, but if somebody else wants to go on, go ahead.
The way you described the brain and on the left side or right side, I thought that was kind of neat because I was sitting here trying to draw it but write it at the same time. But the only thing I don't remember is when I had a test done, I forget which side of the brain or my head that they said the cyst is on. And just lately, everything on my left side of my body has been acting up. And I'm going to try and get online or call Henry Ford and ask him about which side of my brain the cyst is on that's maybe causing the seizures. But
well, I do want to say one thing about that. I didn't say this before, but there on the top of the brain are two strips. One is a motor strip and one is kind of a sensation strip. And the motor strip on the left side controls the right side of the body and vice versa. So if you're having symptoms and same with the sensory strip. So if you're having sensories or sensations on the left side of your body, that might actually be on the right side of the brain that's causing that.
This last week, since I had a seizure, I was telling them a dentist lots of times that I'd cracked my tooth, and then the other day I had it pulled, and I was just hoping that everything will be going back to normal, but I know it takes a while to once you get a tooth pulled, to get yourself situated.
Sure.
Okay. I hear some more sound in the background. If someone could mute your line if you have sound in the background or eliminate the sound, that would be appreciated. Okay, great. Other questions?
I was wondering about
I have a comment.
Okay.
Well, I'm not doing talking about the medication, forgetting to take your medication. And I know, like CVS Pharmacy, they do sell cases, but I know I have one in my pocket for my morning, afternoon, and night. I just go ahead and pull my case out and take medication. If I forget anything, I will look right in my case, and that will take care of it right there.
Right. Yeah, there's so many different solutions available for remembering to take medications. It's really just a matter of finding something that works for you. So, Jenny, you had a question?
Yes, about that. I'm not sure if I'm pronouncing it right. Probably not. Neuropsychological, whatever, testing. The test of significance, I can't even read my own writing. How significant is problem? What can be done? And one of the things, problems and depression, and I do suffer from that some. And do you think I should or could have that test? Or should I talk to my doctor about it?
I would talk to your doctor about it. If the primary problem is the depression, I would start by trying to focus on that and seeing if you can have better control with that and seeing if that helps your thinking skills. But if the primary problem is the thinking skills, and that's the thing that's getting in the way of your life most, then talk to your doctor about possibly having him or her refer you for an evaluation.
Okay, because I do suffer from depression some, but oh gosh, my memory is such a lousy. It's so frustrating sometimes I don't remember something. And how am I going to know if my insurance covers it?
Wow, that's a great question. And
I'm on a super, and I mean super limited budget, and there's no way on this earth I could afford it unless the insurance covers it.
well, I know that over here at Mercy Health St. Mary's, people will call in with that question, and you, I think, have to find out where it is you would have the evaluation done, what codes they use for the evaluation, and then you have to talk to the insurance company about whether or not they support those codes.
Okay, because I have no idea if they do or not.
We could help
where
with that
it's
too.
done in what code? Pardon?
We could help you with that too if you are interested in getting one. We could help walk you through that process. So if you want to call us after the call, we can help with that.
Okay, I could just call later.
Sure. Okay. Other questions from anyone else?
Well, I've got problems with my meds because they make me so tired. But I've been taking them for a long time. So aging makes you more sensitive to side effects?
In a lot of cases, that can happen. So you have, as you get older, some of the side effects that you have may become more severe, and there may be other changes in your life too. So
I
again,
sleep like 10 hours or more a night, and I don't exercise because I don't have any energy.
Mm-hmm. I think that's a conversation for you and your doctor to have, and your neurologist or whoever is prescribing the medication.
Yeah, well, the last time I complained to him, I ended up in the hospital with the grand mal, so I'm a little discouraged here.
Oh, I'm sorry.
Me too.
One of the things a good point you brought up, though, is that as you get older, your body metabolizes medication a little more slowly, and so you're more at risk for what's called toxicity, which is where the levels of the medication in your blood get high enough so that you start to have a lot of dose-related side effects. So side effects that are, most of those side effects are things like, basically if you think about being drunk or intoxicated, the side effects from toxicity are very similar to that, slurred speech, coordination problems.
Well, if only I could drink.
Or just being very drowsy or sedated, those types of things. If you're experiencing those, that could be a sign that the blood levels of your medication are getting too high because your body's not processing them fast enough. So that's something definitely to talk to the neurologist about.
Okay.
Okay. Other questions? Got about 5 minutes left, so now's the time to ask your question.
I have a question.
Go ahead.
This is Hannah. I just had a question regarding executive function. I know we talked a lot about different strategies to assist with memory and attention, but what about executive functioning?
Well, that's a great question, Hannah, and that's a very difficult question, too, because if you think about it, executive functions have to do with attention or paying attention. And it's harder, I think, to signal you to pay attention than it is to give you a cue that you have to remember something, okay? But in terms of what you can do, if you have trouble with your attention, is, again, getting into a routine will help. So if things are not different every day, you would have, they won't surprise you as much, and you would be able to predict that something is going to be happening easier. But frankly, I find that people who have trouble with executive functions, it's harder for them to make the behavior changes than somebody who simply has a memory problem.
Do you find with executive functions, like if you have difficulty with planning or organizing or multi-step projects or things like that, do you find that just like with memory, that writing it down tends to help with that? If you can write things down and kind of have a vision?
If you can, yes, and breaking it down into simpler steps and things of that nature. The difficulty I have, though, is that people who have trouble with executive functions then don't use the strategy or are inconsistent because of problems with attention and focus to kind of do the things that are meant to help.
Right. So
and again, it isn't because they don't want to, but they just have trouble with their consistency.
And that's maybe where family members can help too.
Mm-hmm.
Yeah. Okay.
Have you found that, this is Hannah still, have you found that there are employers that are, what's the word, sensitive to or responsive to assisting people with executive function challenges? Because sometimes I think what occurs is trouble even coming up with the steps, how to solve the problem.
Mm-hmm.
Those sort of things, how to understand a task. And so it takes a longer amount of time to understand an instruction, and attention does certainly play into that, but writing it down doesn't even, sometimes it's what do you write?
Yeah.
Right.
And especially in a world where everything is about productivity and exactness.
That's right. And although I do find that smaller employers are better at accommodations of all types than larger employers. And I also find that often the most important variable is not the company, but the supervisor, the person who is like one step above you, and
right.
whether or not they are skilled at developing effective but simple accommodations for the person who's having trouble. But in general, smaller is usually better than larger, because larger employers have more specific policy and procedure manuals and are it's very important for them to treat everybody the same. And sometimes that doesn't work if somebody needs some accommodation.
Okay,
thank you. Might also benefit from having an appointment with a vocational rehab counselor at Michigan Rehabilitation Services, because they can sometimes provide job coaching and can actually be with you during a probationary period at a new employer and help you get used to here are the types of things you're going to have to do on the average day, and let's work together to come up with some strategies and accommodations to help you succeed. And sometimes once you get those established in that 6-month period or however long the job coach is with you, that might be enough to help you have sustained success.
Okay, yeah, because to ask for accommodations means you need to know what they are, and if you struggle with executive functioning,
right.
And you don't know a new job enough anyway, like anybody wouldn't, that gets really challenging.
Yeah. And it's very hard.
I appreciate it.
It's very hard, too, because on the one hand, it's good for the employer to be educated as to what's going on. On the other hand, sometimes people feel like that telling their employer that they need some accommodations won't help them, but will actually hurt them. It's hard to give kind of general advice. Perhaps the thing to do would be to talk to somebody specifically about your situation and about the risks and benefits.
Sure, it's very scary to speak with an employer and say, hey, I have a disability or a condition that, you may, whether or not you, say as much, discriminate against me for.
Mm-hmm.
Right. I mean, the Americans with Disabilities Act is, in theory, a great idea, and it's, you know, designed to protect against that, but there are so many ways that employers can get around that, unfortunately. So,
yeah. Thank you. That answers my question. I went up.
Great. All right. Well, we are at the time limit. Unless anyone has a really quick question that you were really wanted to get answered. Anyone else? Okay.
I just want to thank the doctor. It was very, very interesting.
Yes, it was.
Yeah, thank you.
It was.
And I would like to thank you as well for all of your time and insights, and it was very enlightening for all of us, I'm sure, and really appreciate your involvement. So thank you, everyone, for being on the call, and the next call we have is on vagus nerve stimulation for epilepsy on October 7th. So if anyone is interested in that, go ahead and contact me and you can sign up. So thanks again.